Well, I have a few minutes after the half an hour, so why don't we get started, everyone? Hi, welcome to the people who joined. I am Scott Allen. I am the CEO for the Family Medicine Education Consortium, and we're excited today to have you hear from Dr. Dan Hoefer. We at FMEC released an online CME series, about a 6-hour course on Palliative care that Dr. Hoefer provided to us using his expertise, and we're really excited to have that available to you. We thought we would have some webinars where Dr. Hoefer could talk a little bit about himself and what Palliative care is by giving some case examples to kind of talk a little bit about what you might experience if you take the course. So there's information on our website on the course. So we hope you'll visit that. We also will be recording this so you can watch it later or share it with friends who are interested in learning more. And with that, I'm going to turn it over to Dr. Hoefer because he has a lot to talk about in a half an hour. Dr. Hoefer is the Chief Medical Officer for Sharp Healthcare's outpatient palliative care program, Transitions, and he's Associate Medical Director for Sharp Hospice Care. And with that, Dr. Hoefer, please take it away.
Thank you very much, Scott. I really appreciate it. And I thought I had more time, so I'm going to pack a 45-minute discussion into something a little bit shorter. I gave you a case study last time about a geriatric syndrome, which is one of the issues involved in palliative medicine. It's also about being sure we practice patient-centered care. It's understanding how to de-intensify care according to Geriatric criteria. And then it's also about understanding clinical guidelines for the advanced elderly. And this is what the presentation is about today. So I'm going to be talking about blood pressure management in the elderly, going beyond sprint so we get it right. I'm just going to tell you that most people practice care using an S-curve. In fact, it's a bell curve, and we should be looking at a person's biologic versus chronologic age. So let's go ahead and get started. If it's going to let me, let's try this way. There we go. Okay, so I have these are my disclosures. I am a paid consultant. What we're going to be answering is what's the proper blood pressure for the elderly, who defines the elderly, and what's the difference between the elderly and the advanced elderly, and why does all of this matter when we manage metrics in our elderly population? So research arbitrarily defines the elderly as somebody aged 65 years or age and older. In fact, 65 years of age came from Medicare as a healthcare benefit. There's no physiologic value in age 65. In fact, I would say it starts at age 70, but it's really just an arbitrary value and historic. What we really need to know about the elderly population is their patient's biologic age is significantly more important than their chronologic age when it comes to practicing proper healthcare management. And I'm going to show you all the research behind that in just a second. And if you look at something like diabetes, the diabetic recommendations that just came out for the elderly 2021 are the best example of a professional society following these physiologic changes, not chronologic changes. And we should be adjusting our diabetic management based on a patient's physiologic and biologic age. Other specialties are starting to follow, but it's taking a little bit of time to get caught up. So what are the principles in geriatric palliative management? Well, number one, you not only have to have a ceiling, but you want to have a floor. So, you want, for younger and healthier patients, you want their hemoglobin A1C under 7. But for the geriatric population, you may want it under 8, but not below 7, as an example. And the same thing goes for blood pressure, and a lot of people are unaware of that. So the other part of that then is, well, since all geriatric patients are not the same, frankly, all patients are not the same, you have to separate them into, are they still very healthy, to determine where that range will be? Are they of average health, or are they of poor health? And the clinical guidelines that we're using for younger and healthier patients just do not apply to the elderly population. Here's one of the things that I refer to frequently. This demographic in that red circle is the advanced elderly population. These are the people with multiple comorbidities, cognitive decline, functional decline, institutionalization, people who were excluded from research because they would skew the results for the body of the patient population that we treat. And we're going to see that in blood pressure management. This is the way we should actually be practicing healthcare. not an S curve. Once you get to a certain point, everything stays the same until you die. Hemoglobin A1C, blood pressure, cholesterol. We should actually be readjusting that basis on the phases of the geriatric life cycle. The SPRINT study, in fact, targeted blood pressure at less than 120, and that's versus systolic blood pressure of less than 140. And they showed that with aggressive care, there was a statistically significant decrease in fatal and non-fatal events and all-cause or mortality with the intensive group. So that's a good thing, and we do want to manage that level of care, apply that proper level of management to our patients when they are in the group for which the research was appropriate. So the question then becomes, who was excluded and what were the adverse events? And who are the elderly and the advanced elderly in this population, and how would we change our care, and why does all of this matter? So I want to read you something that was published almost the exact same time as the SPRINT study. And it was almost divergent in the way you would think about the SPRINT study, because they were pointing out the failures of the SPRINT study at the same time they were publishing the SPRINT study. And this is from the Journal of the American Geriatric Society, but it's from the executive summary of the American Heart Association, the American College of Cardiology, published with the American Geriatric Society. And what it said was individuals age 75 and older have been markedly underrepresented in most cardiovascular trials, and virtually all trials have excluded older adults with complex comorbidities, significant physical or cognitive disabilities, frailty, or residents in nursing home and assisted living facilities. The next sentence in that article is, therefore, medical care for cardiovascular patients over the age of 75 is not evidence-based. And I looked at this population and said, well, this is virtually all of the patients I take care of. And this was published at the same time we were being told to push patients' blood pressures preferably under 120, if not at least under 130. So I was challenged by whether we were actually doing the right thing for these folks. Here's a different study looking at the same demographic as the SPRINT study. This was published in the journal Age and Aging in 2020. Now that's the British UK version of the Journal of the American Geriatric Society. Markedly larger study than the SPRINT study, but it included everybody. They didn't exclude anybody. So 416,000 patients. And they measured blood pressure the way we do in our office. And they showed that there was increased cardiovascular risk if the systolic blood pressure was greater than 150. But the ideal blood pressure was not under 120. It was 130 to 139. Lower mortality for moderate to severely frail patients or age greater than 85. And you can see the hazards ratio. Anything less than 1 means improved outcomes. And the conclusion was a diastolic blood pressure less than 80, a systolic less than 130, opposite of the SPRINT study, consistently associated with higher mortality. In conclusion, in a representative primary care aged patient, 75 or older, a blood pressure less than 130 over 80 was consistently associated with higher mortality. Well, that's interesting because that's not what we're looking at when we use quality metrics for our patients. So how can that be? And the answer is that studies were done by different pathways. In fact, this is the results of that study. If you look at anything to the left side of the middle bar, frail on the bottom, pre-frail, and then healthy would be the darkest mark. So you can see at 75 to 84, their ideal blood pressure for most of these patients looks to be somewhere between 135 and 160. And for older patients, it's even higher. And that's taking all patients. So the healthiest patients, which the SPRINT study took, the average patient, and the least healthy patient. And you can see that lower blood pressures actually increased mortality. Here's a different study showing the same thing. Nadir of mortality for this group is probably somewhere around 135 to 160. And these are people aged 75, 80 years and older, 80 years and older for this study. Well, what about the right side of the bell curve, the sickest of that population? And this is the Partridge study. This is from nursing home patients. They looked at people having their systolic blood pressure pushed under 130 with 2 or more blood pressure medicines, and they found that the hazards ratio for mortality, if you push that blood pressure below 130, increased to 1.81, so an 81% increase in mortality if you were pushing these frail elderly patients' blood pressure lower. And that's what that looks like. So the control group is on the top. These are patients that did not use 2 blood pressure medicines or systolic blood pressure remained above 130. And the bottom line is people pushing the blood pressure lower with 2 blood pressure medicines. And if you break all of the variables apart, you can see it's just the people pushing the blood pressure under 130 with 2 blood pressure medicines that had the highest mortality. Well, what about another trial looking at 80 years and greater, the effects of antihypertensive medicine reductions on outcome if you stop their medication? And what they did is saw systolic blood pressure less than 150. These were outpatient clinics. And they said, well, if they're on 2 or more blood pressure medicines, their systolic blood pressure is less than 150. Should we stop one of the medicines? And they did this randomized trial, and they found no statistically significant increased risk of cardiovascular events or negative adverse events if they stopped one of the medicines for a systolic blood pressure less than 150. And they did have a slight increase in the systolic blood pressure, went up by 3.4 points, and that is significant. And people who manage blood pressure know that that is a significant number. And people looked at this study and said, well, there was not statistically significant. 12 of 226 patients in the intervention group, 7 of 236 in the control group, usual care. And you might say, well, that may not be statistically significant, but it looks like a trend. The critics of this research said, well, yeah, but in the intervention group, they included adverse events such as a hernia repair, or things that normally would not be represented by a blood pressure as a problem. And the better evaluation would have been 9 out of 228 and 7 out of 236, which makes the statistically insignificant information more palatable. But what I want to show you about the study in particular, because we care about the way our patients feel. And when we stopped blood pressure, just 1 blood pressure medicine, 9 out of 11 metrics improved. That is the 4th line over, adjusted risk difference. And you can look at issues. They looked at stiff joints, pain, fatigue, loss of strength, breathlessness, sleep difficulties. You can read the list, and you can know that all of our patients complain to us about these things all the time. And you can see there are only 2 issues, and one is questionably just an expected side effect because of reperfusion. You get that pins and needles feelings, it goes away. So there was benefit symptomatically in lowering these patients' blood pressure medicines. There's something that's almost never talked about, which is that blood pressure affects cognition. This was a study published on older adults with hypertension in the Annals of Family Medicine about 3 years ago. Looked at patients 75 years of age and older. If the systolic blood pressure was under 130 by medicines, the reduction in MMSE per year was 0.9. If it's over 130, the reduction in cognition was 0.14. And this is one of the things our patients care about most. There is not enough research going into this, but this is just an example that there are other metrics we have to look at in our elderly population that they actually care about significantly. Now, people will say, well, the Sprint Mind study showed there was improvement, and that's correct, but that was patients age 55 to about age 80, and that skewed the results towards that younger and healthier population. There was a 19% reduction in the risk of developing mild cognitive impairment. This is just another study I want to show you, recently published 2 years ago, that when people get older, the risk factors for cardiovascular events are not the same as younger and healthier patients. And I just want to show you something not related to blood pressure, but I want to show you quickly that the nadir of mortality for total cholesterol, which people aren't checking very often because we're perseverating about LDL, is 201 to 250. And if you look down at systolic blood pressure, it takes about 0.7 to be statistically significant. There is no benefit over the reference range for most of these patients that keep their blood pressure that low. If you look at systolic blood pressure and managing risk of cardiovascular events in the advanced elderly. The question, of course, then becomes, are people de-intensifying care according to clinical guidelines? Geriatricians claim they do that, internists, primary care, cardiologists. The reality is that on our community-based palliative medicine program, we would say the majority of patients come onto our program and we have to adjust their care to the clinical evidence-based guidelines that should have been started, frankly, years earlier. And I wanted to point out that the reasons for adjusting care are different. Limited benefit, you can see the green line in the second grouping. That's geriatricians, palliative physicians saying they stop lots of medicines because of limited benefit. And then if you see the second from the bottom, concern about cognition, that is something that geriatricians also worry about. That's something I think that we should all be thinking about, not only because of the anticholinergic side effects, but the total blood pressure and other issues that affect our patients' cognition. So what did all this summarize up to with the various medical groups? That's why there's no new JNC, that nobody agreed. But the definitions were different from the American College of Cardiology and the AHA, the American College of Physicians, the American Academy of Family Physicians, the European Society of Cardiology. I think the European Society got it the best, but as you can see, the variables about when to start pharmacotherapy are markedly different. At least the European Society of Cardiology talked about the elderly and the very old. None of them commented about biologic age versus chronologic age, and that's very important. We'll talk about the difference in just a second. This is an article published from the American College of Cardiology in 2020, and if you forget every slide I've shown you, remember this. And I'm going to look at the right grouping on the bottom. That is systolic blood pressure versus hazards ratio for mortality on the y-axis. And if you look at the circles, the dark circle and the light circle, for younger people, less than 60 or 60 to 70, the nadir of mortality is the systolic blood pressure under 120. But look what happens when you get to 70 to 80 or 80 and older. The nadir of mortality actually is about 140. And mortality rises when you push that blood pressure down. And the same thing for diastolic blood pressure for everybody. So when you get a diastolic blood pressure under 60, you're actually raising mortality. Now, and this is something I'd like you to see as the accumulation of this slide. Look in the right upper corner. They looked at age and they showed the nadir of mortality for less than 60 is 110. At 60 to 70, it goes to 115. At 70 to 80, it goes to 135. And over 80, it's 140. So we're supposed to be letting our systolic blood pressure rise as people age as a generalization. Not a whole lot of people are doing that or realize that they should be letting their elderly patients' blood pressure rise to lower all-cause mortality. So what happened after the publication of the SPRINT study? Well, not even cardiologists agreed with the recommendations. This is from the ACC. The current guidelines recommend aggressive blood pressure lowering in older patients, including those with ischemic heart disease. The evidence of intensive systolic and diastolic treatment in this population is inconclusive. To date, prospective randomized trials to define appropriate thresholds have not been performed until more conclusive data is published. Individualized targets based on comorbidities, quality of life, and patient preference should be applied when making a blood pressure treatment plan in this group. And that's why I showed you the issues regarding quality of life and cognition and some of the newer literature about where blood pressure should actually be. This is the HIVET study. Some of you know about this, but is there a ceiling for the elderly population? Blood pressure management for systolic blood pressure greater than 160, target of less than 150 over 80, and there was a statistically significant decrease in strokes, heart failure, and 21% reduction in mortality. So there does appear to be a ceiling somewhere around 155 to 160. And you can look at all of the cardiovascular trials that have occurred over time. But what about the SPRINT study then? So that was for 75 years of age and older, lowered systolic blood pressure from 140 to 120, 34% reduction in MI, stroke, heart failure, and cardiovascular death. You think automatically we should be applying that to everybody. But there's some problems with that. There were multiple people excluded from the SPRINT trial. And I want you to think about your practice while I'm showing you these. How many of your patients have multiple comorbidities? They were excluded from the trial. Cognitive dementia or cognitive impairment, excluded. Loss of autonomy, excluded. Diabetes, history of a stroke, or medical conditions with a life expectancy of less than 3 years. There was lots of harms to SPRINT: hypotension, syncope, acute kidney injury, electrolyte abnormalities, and polypharmacy. In fact, 19% of our patients in the elderly population already have postural hypotension, so they should not be getting their blood pressures pushed lower. The other question is how many patients in the SPRINT study were over the age of 75, and that was 18%. That's actually a pretty good number. But when they went and looked back with all of those exclusionary criteria, 2 studies looked at that. Typical family practice, the number of patients from the SPRINT study represented in our practices is only a quarter to a third. The other 2/3 to 3/4 were excluded from the research. In fact, this is the exclusionary criteria, and I don't know if you can see that. So that's the HIVET. There's a lot of exclusionary criteria optimized on the right, but in the middle is SPRINT, and you can see all of this excluded, 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 excluded. What did they do? They took the absolute healthiest segment of the geriatric population and inappropriately applied it to all patients. So the question, of course, then becomes exclusionary criteria may not mean that you shouldn't include that and those people are excluded. But I've shown you some research already that says, well, unfortunately, yes, they should not be pressured to the lower blood pressure to the levels that we are being recommended. So now that we have a lot of that research, we have to reevaluate whether our recommendations are actually correct for this demographic. One of the things you can do to improve your prescribing is look at something called time-based prescribing. And this means you need to start looking at patients' life expectancy, their quality of life, time to benefit and harm. And then you have to do something that's particularly important. It's overcome inertia. That is the inertia of decades of getting patients' blood pressure, hemoglobin A1C, and cholesterol lower and adjusting it to where they are in the patient's bell curve of their life cycle, not the S curve for which a lot of healthcare is practiced. And just to give you some timetables, if you want to reference, you can look at men and women and how long they live. And you can say, well, anybody that's in the light shade that's under 5 years or under 10 years, those are particularly important cutoff points for when we should start thinking about de-intensifying care. This is an example of the adaptation of the American Diabetes Association's recommendations for decreasing diabetes intensity. And you can see for patients greater than 10 to 15 years compared to less than 5 years, look at the appropriate range for hemoglobin A1C. It's 8 to 9. A lot of people don't realize that. So we have people coming on our community-based palliative medicine service for which the patient has 2 years to live and their hemoglobin A1C has polypharmacy pushing their hemoglobin A1Cs down to 5, even to 6. And we should have had those medicines stopped years earlier. So we stopped them for them. But here's a simple tool you can use for your blood pressure. This is the timed up and go test. Well, I don't know what to do with my patient's blood pressure. The timed up and go test is when you stand up out of a chair, walk 10 feet, turn around and sit down. If you can do it in less than 10 seconds, you're a fast walker. Slower walkers are 10 to 20, and unable to perform or failed test is greater than 20 seconds. And this is for mortality with the systolic blood pressure greater than 140. So fast walkers do benefit. A hazard ratio greater than 1 means there's a 35% increase in cardiovascular events. But if they were slow walkers, there was no benefit to lowering their blood pressure. And if they were unable to perform the test, pushing that blood pressure lower increased the mortality rate by 62%. So that hazard ratio of 0.38 of keeping their blood pressure above 140 actually decreased their mortality. And that's the study. And the did not complete less than 140 blood pressure were on the bottom. That was the highest mortality rate. The lowest mortality rate was the fast walkers with blood pressures under 140 on the top. I just want to show you that polypharmacy matters. I used to show this slide and people would say, well, they're on more meds because they have more problems, but nobody was adjusting their meds. We can routinely decrease 10 or more medicines, which is the line on the bottom, 5 or less on the top, 75 to 80 on the left, 80 to 85 on the right, by understanding Beer's criteria and clinical guidelines and the problems with polypharmacy in the elderly. And that's mortality rates after 5 years. You can see the huge difference that polypharmacy causes in our elderly population. So de-intensification of care saves lives, following clinical guidelines for blood pressure. This is my conclusion. I'm not going to read it because we don't have enough time. You can look at all of the recommendations we put out for our patients in our medical group. And thank you. And I know that was very quick, but I hope that gives you some understanding about how we need to be adjusting care for our elderly population when it comes to blood pressure. Any questions? And Scott, can you please read them to me because I don't have the chat box.
Sure. Thanks, Dr. Hoefer. That was very interesting. I'm sure people are learning a lot. If you have a question, you can either put it in the chat box or you can raise your hand and I can take you off mute. So while you're thinking of questions or comments or suggestions for us, I'll remind everyone that there's more content through the FMEC website. If you want to visit there and sign up for the Dural Palliative Care course that we put up there, you'll hear more about these topics from Dr. Hoefer. There's a question, Dan, from Susan Bowman. Can we get either the slides or the references? We can share the slides. I will say that, Dan.
All the references are on the slides. And anything that didn't have a reference is in JAGS from the last couple of years. So I read JAGS and I pull articles from other research articles, so they should all be there. They should pretty much all be cited.
Okay. So after this, we will convert the recording to a video you can all watch, and we'll send that out and have the slides with it. So
great. And think about this, you know, we're doing as best we can. Population Health did a great job capturing all of those patients that hemoglobin A1C, their blood pressure was too high, and I think we're doing a better job managing the healthier and younger population, getting them to clinical guidelines. But to some extent, it has done that at the expense of the advanced elderly, right side of the bell curve that I've spent my career. Because these patients are getting over-medicated, and there's a lot of moral resolution that goes into physicians thinking they're doing the right thing. And when I show them this data, they're a little bit shocked that nobody had ever told them this. So, and some of it's new, but this is, some of it's not. So we need to be really careful about what we apply and how we evaluate our elderly population. My other comment would be that we have a lot of younger patients that don't have a long life expectancy. So a 72-year-old smoker that's got a slow-growing lung cancer, they should not be held by the same standards for diabetes, cholesterol, blood pressure as the healthier, younger and healthier population. For a statin, for example, it takes 2 to 5 years to prevent a heart attack and 4 to 5 years to prevent a stroke. And we do know in a randomized control trial by Amy Abernathy for primary or secondary prevention, when you kept the patient on a statin in the last year of life, they lost 39 days of life. And there was statistically significant worsening in their quality of life when they stayed on their statin. So that's the type of education we need. There's two sides to a bell curve. And we really need to start doing a better job managing that right side, which really means we're managing our patients until the very last day of life.
Great, thanks. We did hit the top of the hour, and so I want to be respectful of people's time. If you need to sign off, we have one question, which will, Dan, why don't we get to that and then sign off? The question in the chat is, how do you measure biologic age?
Biologic age is learning some professional skills about where the patient is in the life cycle. So learning what it means, for example, if a patient develops hospital-induced delirium and they're age 80, 80% of those patients will be dead in 3 years. That's a warning sign. Pressure ulcers are not common in the younger and healthier population for a good reason. They have good physiology to withstand care. Pressure ulcers, multiple pressure ulcers, can be a poor prognostic long-term sign. And so you have to learn all of these signs so you know where the patient is. You can do the timed up and go test as a reference. So there's lots of pearls out there. Those are some of the things you would learn if you took the Dural Palliative course.
Great. Well, thank you again, Dr. Hoefer, and thanks everyone for joining today. We will send a link out to the recording, and if you have any other questions, just reach out to the FMEC. So thanks everyone. Have a great rest of the afternoon.
Great. Thank you, everybody.